almost afternoon. I'm so impressed with anybody and everybody who's been here all morning. I want to give you a little background about this particular talk today. So I've been married 20 years this October. So a lot of these talks I'll have my husband listen to. So he knows a lot about gynecology. And he told me I got a little bit in the weeds about this, so I kind of went back and I revamped a little bit. So I hope I don't get in the weeds too much. Really the goal for me today is to kind of take you through a little bit of the history of hormone replacement therapy, in particular to heart health, and also to talk specifically about the Women's Health Initiative, which is where we've gotten a lot of our information regarding heart health and hormonal therapy. When I do talks that involve hormones, you know, that's a sort of really broad title, and I may not actually talk about what it is that you wanted me to talk about. So I don't have 45 minutes worth of material because there's always lots of questions. And I'm really happy to answer any questions that you have. And then if we get done and we run out of time, I'll hang around a little longer. You can come up to me and we can talk afterwards too. So thank you so much for being here. And I don't have any disclosures. I just work for Cone Health. And but I do use some of the branded names of hormones when I'm talking today, just because it's easier. And some of the generics, I mean, sometimes I see generics on patients' med lists, and I'm like, what the heck med is that? I have no idea. I have to look it up. So, so if I use the branded names, it's just sort of for ease. But no pharmaceutical companies pay me anything. And then, so some background information about hormones and heart health. I really want to talk about the Women's Health Initiative, because most people think that's a breast cancer study, and it was not. So we're going to get to that. I want to talk about some of the current thinking, so what we knew, what we thought we knew, and sort of maybe what we hope we know, and then sort of when to and when not to use hormone replacement therapy. There definitely are some contraindications and some things we should think about in deciding who should be on hormone replacement therapy. Hopefully it's lots and lots of questions, and I hope to keep you from doing this. All right, so a little bit about me. I'm married. My husband's name is Mark. We met in college at Duke. We broke up for 10 years, and then we got back together. So we got married in our 30s. I have one child. Alexander is 12. I was 40 when he was born, so you know how old I am. And I've lived in Greensboro and worked for about 19 years. I'm now at the Center for Women's Health Care. I've been with that group about 4 years, and I'm out at the Drawbridge location, which is a beautiful facility. Folks come in and say, "Oh, I love your building." I wish I owned it. I do not. The former practice I was in was Greensboro Women's Health Care, so I do primarily focus on now gynecology and surgery, but we still see OB in our office as well. And I do enjoy playing piano and baking and reading and traveling. I love traveling. All right, so 2 landmark studies that were before the Women's Health Initiative. A nurses' health study, and then a study that was called, it's a lot of words, the postmenopausal estrogen progestin interventions trial. And in medicine, lots of trials get nicknamed things. So this is the PEPI trial, and that's mostly what I'll call it, the PEPI trial. So the nurses' health study, this is not new. This is a long time ago, 1976. It was led by an epidemiologist and a physician who worked at Harvard. It started as a prospective study, which means you're sort of starting at a point and looking forward and following what happens with women over time. And it looked at this epidemiology, which is just a study of disease in a population, and it was looking at the long-term effects on nutrition and hormones, environment, and work-life balance on heart health and disease. And it was called the Nurses' Health Study because it studied nurses. So it was about 120,000. It's a big study. Nurses, when they were aged 30, and it's women, age 30 to 55. It looked at 11 of the most populous states. It was a survey. Initially, it became twice a year. Then it started to include additional pieces of information, blood work, urine samples, salivary testing. It had a second part in 1989, and then a third part in 2010. So these are women that got followed a really long period of time. So what this study showed was that postmenopause, now it showed lots of things, but we're focused on hormones and heart today. So it showed that postmenopausal hormone replacement therapy was associated with a lower likelihood of cardiovascular disease. So one piece I want you to remember out this is that these were women 30 to 50 who were studied. So age is important. So wait. Back in the 70s, we started a study that showed that hormones could actually lower our cardiovascular risk. Okay, so why are we still talking about this? There are a couple other things in the study that I think just have to do with hormones that are important to mention. And this study showed that oral contraceptives, either prior or active use, didn't increase risk of heart disease. So that's sometimes a question that I'll get from younger folks is about hormones and birth control pills in particular. So the PEPI trial, this postmenopausal estrogen progestin interventions trial, started in '87. It was published about 10 years later in JAMA. There are certain journals that are like really good, peer-reviewed journals, and the JAMA, the Journal of the American Medical Association, is one of those. So in general, when a study gets published in a journal like that, that's a pretty significant achievement for the individuals who did the research. So this was an important study as well. It was a prospective, it was many centers, and then it was a study called a randomized double-blind placebo-controlled trial. This is like the most expensive study to do, it's the hardest study to do, and you're taking individuals, you're randomizing them, and in the randomization process, usually what happens is that the populations that are investigated are very similar because it's a random process, and you're comparing an intervention to a placebo. So you're really looking at what does this particular thing we're trying to answer question, medication we're trying to look at, what does it do in comparison to a similar population who's not getting that intervention. It was 875 women aged 45 to 64 with no contraindications using HRT, and was looking at selective heart disease factors in healthy postmenopausal women. So what specifically was evaluated was looking at HDLs, which are your good cholesterol, blood pressure, serum insulin level, and then fibrinogen. So what was found was that HDL levels went up, so your good cholesterol went up in women that were either on estrogen or a combination estrogen-progesterone therapy. Your LDLs, your bads, were lowered by about 16 points. That there was no change in blood pressure, and then there was lower fasting glucose levels in all the treatment groups, which would be estrogen or estrogen and progesterone therapy, compared to placebo. So another study that's not new that showed benefit for your heart in using hormone replacement therapy. So what happened next? In the 80s, most cardiovascular studies in the US were heavily weighted toward the investigation of heart disease in white men. And in 1990, the National Institutes of Health created an Office of Research on Women's Health. April 9, 1991, the first female director, Dr. Bernadine Healy, was appointed, and 10 days later, the Women's Health Initiative was announced. So the Women's Health Initiative was a massive study. It was focused on strategies for preventing heart disease, breast and colon cancer, and bone fractures in postmenopausal women. So postmenopausal women, this is an important thing about this study in comparison to some of the information we had previously. 160,000 women were enrolled between 1993 and 98, and it has two big components, a randomized control trial and then an observational study. And one of the really important pieces of this study was the goal was to try and match the number of enrollees to what the population in the US looked like at that time. So the goal was focused to enroll at least 20% of the women in the study who were representative minorities in the United States at that point, where the population at that time was about 17%. So we're going to talk more about the hormone therapy trial. That was the double-blinded randomized controlled trial that was a part of this. And then the other two pieces were dietary modification and the calcium and vitamin D trial. So it was originally started to be a 9-year study. And this part of the study had about 30,000 women aged 50 to 79. So remember the nurses' health study? That was like 30 to 50. The women were aged 30 to 50. This was aged 50 to 79 with a mean age of 63. So what we've known from some other studies about hormone replacement therapy is that if you have a uterus and you're on estrogen, you need progesterone. Estrogen alone, we call unopposed estrogen. We're not giving anything with it. It can cause something called endometrial hyperplasia, which is a thickening, a precancerous cell change in the lining of the uterus, and unopposed estrogens can ultimately cause endometrial cancer. So if someone has a uterus and they are on hormone replacement therapy, they have to be on progesterone. So women who've had a hysterectomy can be on estrogen alone. So this study looked at estrogen and placebo, and then hormone replacement therapy, estrogen, progesterone, and placebo. The primary outcome of the Women's Health Initiative was not breast cancer. That is what made the news. I remember when this made the news, and it was about breast cancer. This was a heart disease study. It was looking at whether hormones were going to improve heart health and decrease cardiovascular risk. The other outcomes they looked at were things that we knew estrogens do have some role in, which is stroke and pulmonary emboli. We know estrogens are a procoagulant. They do increase the risk of clotting, endometrial cancer, colorectal cancer, fractures, and then this kind of catch-all, death due to other causes. So again, this was a heart study. The results were looked at every 6 months. So when you're doing a study like this, you want to see, so you're not looking at the data all the time, but you want to have some intervals where you're looking at it to see if there's really some risk, you want to stop the study. If there's really some benefit, you might actually unblind the study so that you've got more data and publish earlier, or at least give some preliminary data before the study's actually completed. So after about 5 years, so this was a 9-year study, that was the original plan, but after about 5 years, the Prem-Pro, the estrogen and progesterone group, that was stopped. And it was stopped because what was seen in the study, that there was an increased risk of heart disease. There were more heart attacks in women who were on Premarin and progesterone. But again, remember that this group of women was an older group of women that had been seen and that had been investigated compared to prior studies. They also saw increased risk of stroke and pulmonary emboli, and then the safety outcome that was monitored was breast cancer, and that was also seen. So earlier in the study, they start to see some divergence between the group of women that were getting Prem-Pro and the placebo, and as that got to where the safety where it looked like this was really some information that needed to be shared earlier, they just stopped and unblinded the study, and that's what really hit the news, that the study was stopped early, but more focused on the breast cancer piece. Now, interestingly enough, hormone replacement therapy in this study showed a decreased risk of colon cancer, which has been seen previously. That seems to bear out. So women who are on estrogen, for whatever reason, have lower risk of colon cancer, and estrogen is good for your bones. So absolutely have a decreased risk in fractures in women who take hormones. So the big picture about this was combination HRT in this group of women looked like it increased the risk of heart disease. Now, the Premarin arm, the estrogen alone arm, that kept going because it didn't have as many risks. It ultimately was stopped close to 7 years instead of 9. And it was stopped not because the risk was increased, it wasn't decreased. And that was really the point of this study, was being on estrogen good for your heart. So the data at this point was showing no increased risk, but no increased benefit. So safety pieces, stroke was also seen. It also showed decreased risk of fractures. And then this part of the study, which is very interesting, is that estrogen alone did actually not show increased risk of breast cancer. So there's a lot to kind of dig into this study. This was where my husband said I got in the weeds too much. So just want to try and give kind of big picture. which is that estrogen didn't increase cardiovascular risk. And the other thing it didn't do is it didn't increase risk of breast cancer. So the progesterone actually makes a difference, and it matters. So yeah, why were there differences? We know now that the women that were enrolled in this study were older. They were an average of 63, where most hormonal studies have been done on women that were perimenopausal, so sort of more like the 45 to 55-year-old age. That's when most women go into menopause. Average age in the US is about 51. So this is 10, 12 years after sort of the average person goes into menopause. Also in the study, which is information that sort of came out after and looking back at it, was that women in this study tended to be slightly overweight, and they were more likely to have been a former smoker, which is just an interesting finding. And we know that smoking is not good for your heart. And then the other sort of, I would say, criticism of the study is that the study focused on one estrogen, Premarin, which is a horse-derived estrogen, it's an equine estrogen, and then a particular progesterone called Provera. And there are at least 4 or 5 other progesterones that we can use with hormone replacement therapy. So some thinking is that the progesterone in this study also is important. So what have we learned since? Yeah, that we've looked at this more critically. And if you look at the group of women in the Women's Health Initiative who were in a sort of more a typical age of going into menopause, being perimenopausal, that age range of women sort of 50 to 59 instead of the 60 to 79, which is actually about 3.5% of the women in this study, that group of women did not have an increase in heart disease, and in fact had a pretty substantial decrease in their chance of developing a heart attack. So 40% overall lower MI risk. And they also had an overall all-cause mortality rate than women who were in the placebo group. So the younger women in the study, it looked like actually estrogen's better for the heart and decreases mortality. So a couple of those studies that have come out since then, there's a Danish osteoporosis study, and it was really focused on osteoporosis prevention, but it had other parts of the study that it was looking at. It's about 2,000 women that were followed for 16 years, and they were enrolled right around the time of menopause. So this study, right at age 51. And one of the findings was that women in this study that were on hormone replacement therapy, they had low rates of heart attack, heart failure, and death. So I think one of the things we've learned since the Women's Health Initiative, particularly about heart health, is that it does matter when you start hormone replacement therapy. Age is really important. So another thing that I just mentioned was that the women in the Women's Health Initiative were more likely to have been former smokers. And so smoking history, it does matter when we're thinking about who we're going to start on hormone replacement therapy. I talked a little bit about the estrogen that was in this study and the progesterone. So one of the things we know about Premarin is that it does increase inflammatory markers in the blood. A big one is called CRP. And so one of the thoughts about inflammatory markers of inflammation in regards to your vessels is that as we age, we're going to get plaques in our vessels. So if you are on something that's going to increase inflammation, it could cause the plaque to shear off or the plaque to rupture, and that's how you get a heart attack or how you get a stroke. So that the estrogen, Premarin, is the most inflammatory causing estrogen. The trend now is to use estradiol, not Premarin, and to use a transdermal instead of an oral. So those two things seem to lower some of the risks related to estrogen. And that progesterone, although progesterones in general aren't high risk for forming clots, that Provera, the particular progesterone in this one, is the progesterone that's most likely to cause a clot. So a clot in a small vessel, particularly around your heart, that can cause a heart attack. So in this study, the Women's Health Initiative, maybe the particular estrogen and the particular progesterone that were chosen, they weren't the ideal ones for women's health. So I think it matters which estrogen and progestin we give patients, and I think it matters the route in which we give it, meaning oral or transdermal. So what do we do with this? So in my practice, I think the timing of HRT really matters, and it does appear that starting estrogen earlier have more cardioprotective effects. And so that perimenopausal time is really the time you're thinking about when you're gonna start hormone replacement therapy. Really, none of the studies looked at the primary reason that women come to me and talk about hormones, which is vasomotor symptoms. So I think the other thing when you think about hormones is that hormones have an impact on quality of life. And I think sometimes we get stuck on one particular thing, which is breast cancer, and we need to sort of step back and think about big picture. So I think the choice of progesterone really matters. So most of the time I use a progestin called micronized progesterone. There was a brand new one called Prometrium. Most of the time now it's just substituted with the generic, it's a lot cheaper. But it has less clotting risk. And then of course, thinking about individual history. So who can think about hormones? I mean, the most common reason that I, again, talk to women about this is vasomotor symptoms. But I will say in the last 5 years, there are more questions about not just hot flashes and night sweats. So vaginal dryness, dyspareunia, which is pain with intercourse, vaginal estrogen, it can be really beneficial. We know that there's estrogen receptors in the vaginal tissue, and that when the estrogen goes down, there's less collagen production, which means the tissue is tighter, it's thinner, there's less moisture. So this is a much more common reason that women talk to me about hormones. And then other menopausal symptoms, which I would say 10 years ago, I didn't talk so much about with folks, but I do now, because I think we're more aware of some of those sort of other symptoms that go with menopause, in particular, mood changes, anxiety, depression, brain fog, and energy. And I get a lot of questions about weight as well. So who really should not use hormones? There are some absolute contraindications. So anybody's had a clot, a thromboembolic event, a DVT, a deep vein thrombosis, a pulmonary embolized stroke, absolutely you should not be on estrogen. I do not write estrogens for anyone with this history. And if you have an active breast cancer, most breast cancers are estrogen receptor positive, so we don't want to be giving something to stimulate a cancer, particularly while someone's actively having therapy. Estrogens are kind of processed and cleared through the liver, so active liver disease, if somebody that's got an active hepatitis or cirrhosis or anything that's going to change liver enzymes, that's not a good person to put on hormone replacement therapy, because it actually increases risk of clots. And then someone has already got a history of significant cardiovascular disease. So there are some, those are the hard no's, and then there's some that you really just need to think about, so we call them relative contraindications. So age, and I say relative because I don't have a sort of a hard, like, at this age I will not talk about hormone replacement therapy, and because it depends also on when a woman goes into menopause. So if somebody that goes into menopause at 56, is it reasonable to have some conversation at 57, 58, 59, 60? Sure it is. If somebody is at 45, is it reasonable at 60? Well, that's a 15-year gap. So that's the part where I think an individualized discussion is really important. We do need to think about other health risks, and particularly mobility, because estrogens do increase the risk of clot. Of course, cancer history, breast cancer history, and then any other cancer that estrogen might impact. So the benefits of hormone replacement therapy, I think the evidence really does show starting estrogen at the right time decreases cardiovascular risk, so some benefit for cardiovascular health. We know that estrogens are good for your bones, that estrogens do decrease the risk of colon cancer, they do help vaginal dryness, painful intercourse, they help with hot flashes and night sweats, they can help with sleep, I think they really can improve your overall sense of well-being. It doesn't help you lose weight. It's a question that women ask me all the time. Estrogens are really not going to help you lose weight. But if you sleep better and your energy's better, that might impact weight. If you feel better, you might be more active, that might impact weight. They do not stop you from aging. We're all aging. But it does seem to make skin better. I don't know if that's the best reason to start estrogens, but it's a question I get. And then it does not absolutely prevent you from developing heart disease. So I think the Women's Health Initiative was really confusing. It hit the news, everybody stopped their hormone replacement therapy. I mean, we just got tons and tons and tons of phone calls from women that were immediately stopping their hormone replacement therapy. So I think the data and the information that we have now about that, kind of looking back, is giving us some more information, and maybe thinking about hormone replacement therapy is not as scary as it seemed like it was then. I use an individualized approach when I'm talking with patients about hormone replacement therapy. And I hope that your provider will do the same thing for you. I feel like, as I said before, it's not about a specific age that's a yes or a no, or a specific health history, except in a few cases, that's an absolute yes or no. I think it's really a big picture. So I consider family history, breast disease, cardiovascular disease, family and personal history. I usually try to start with lower doses. Why start up here if down here gets you what you need? You can get the benefits without maybe some of the risks. I do try to decrease hormone replacement therapy over time. And I do try to stop around age 65, but I can tell you I have a lady I saw just last week, and she's 86, and she's still on her a little bit of estradiol, and like, I'm not wrestling away from her. She's doing great. She can have it for the haul. I think it's just about talking about risks, every year, talking about risks. I do think about, the individual cardiovascular disease risk for a patient, and so sometimes we don't have a lot of history for someone. There are some other tests that are out there now that are a little more easily available, not just a lipid panel, but lipoprotein A, and also coronary calcium score that can give some information about heart health. And then there are times when I do really include other providers. And so if somebody's got rheumatologic disease and they've got other autoimmune disorders and other inflammatory conditions that are going on, there are some particular, I'm trying to think of, recently I've reached out to cardiology, I've reached out to rheumatology, I'm thinking about some different patients, gastroenterology. So there are times when I really want to loop in another provider and making the right decision for a patient. And the lovely thing about electronic medical records is that it's so much easier than it used to be. So I do sometimes say, I need to phone a friend, I need to phone one of your other providers, I need to communicate with one of your providers, and let's have a call, let's communicate about what's like the best thing for you, not just in the gynecology world, but all the things that are going on with you.